Thank you, Joe, and thank you everyone for being here. I find a useful way to frame the transfusion medicine field is to think about the process starting from the donor arm to the patient's arm and what has to happen in between. And Charlie and Joe have talked about the blood procurement side. So getting from the donor arm, all the testing, all the effort in recruiting a donor, all the testing, the safety, and then it gets dropped off at the hospital door. What happens after that? And that's my role in this process is how do you get the right product, the right dose, the right time to the patient? And so that job depends on my knowing what's coming in the door. As we've talked about, if I have uncertainty about how much blood I have that day, there's a whole ripple effect down of what's going to happen in the hospital. So I'm going to talk about that. I also want to make this a little bit fun, and I'm going to ask you some questions. And so how many people here know their blood type? All right, Dr. Waters and Dr. Kiss, you can't answer. What are the 4 blood types? Just shout out if you know a blood type. Shout. Mm-hmm. O. AB. Who said AB? Good, very good. And so A, O, B, and AB. And so these are the percent represented in the general population. So about 40% of us are A, so there'll be plenty in the room. 10% B, maybe a couple. 45% O and 5% AB. And we need to know the patient's type to safely transfuse them. And we need to know the types of the units that we're getting so we can select the right ones. That's called compatibility testing, and that's what's happening in the laboratories in the hospital. We're testing patient samples, determining their type, finding the right components, testing their blood with these components to make sure that they're safe, and then providing them in a timely manner to the physicians. Everybody heard the term universal blood donor? What type is that? O. Right, so O is the universal blood donor for red cells. And so you could see why we keep going back to O donors. Because what do we do for patients who we don't know their blood type? A trauma patient that comes in, what's the only option? Is O. So that 45% of blood donors ends up supporting about 55% of transfusions because of the need to transfuse patients before we can do their blood type and trauma. We even transfuse out in the field on helicopters and on ambulances, and that has to be O blood. So the pressure on O, we'll come back to in our discussion, is really where the biggest pressure is on the blood supply, is group O. Anyone know, here's an advanced question, the universal plasma type? AB. Right. So AB plasma is the only type of plasma you can give to any patient, and that's only 5% of the population. So we have a real challenge in getting enough AB plasma as well. So when we talk about blood shortages, we talk about it in general because most people, we don't have the ability to educate, but it's really focused, particularly on O blood and particularly on AB plasma. I'm going to show you what each of these blood components looks like, because if you're going to get into this, people will ask you, and I want you to have that information of what is a packed cell, what is a unit of plasma, what is a unit of platelets. Packed blood cell is by far the most common product we transfuse. In fact, it's more than all the platelets, plasma, cryoprecipitate put together times 2. As Charlie said, 10 million units a year. Blood transfusion is in the top 5 most common medical procedures in the US. It's extremely common. And as we've talked about, hundreds of times a day across the UPMC, AHN hospitals that I support, we're transfusing. Each unit is about the volume of a can of soda or a large glass of wine. And we transfuse generally 1 unit for each time for a patient. And if they're particularly anemic or actively bleeding, we may have to transfuse multiple units. They're stored in a refrigerator. And as was mentioned, this is a board's question for our residents. The storage time is 42 days. So we have 6 weeks that we're limited. So if we collect too much and we can't use it within 6 weeks, we get an outdate, and I'll come back to that in a moment. And what's the reason? Because red cells deliver oxygen to tissues. So as patients become anemic, we need to help them improve oxygen delivery to tissues. It's that simple. What do you think our outdate rate is of red cells? How good are we at matching what we bring into the hospital and collect versus transfuse? How many people think it's half of 1%? How about 2%? How about 5%? How about 10 and 20? I'm glad no one said 20. That would be embarrassing. The answer is 0.5, and it's actually closer to 0.3 or 0.4, which is 3 or 4 units out of 1,000. That's how carefully we manage these processes, because it's a precious resource, right? We talked about the personal act of donating. We take that very seriously in the hospital. We monitor outdates. We monitor wastage of every single unit. We send a unit to the floor and it gets spiked but not transfused. We look into why that happened for a single unit, even though we may be transfusing 100 that day. So the hospital takes very seriously the issue of this precious resource. Another product that we transfuse commonly are platelets, about 2.2 million doses a year of platelets versus 10 million red cells. The majority, 95%, we collect on a device called an apheresis machine. I'm an apheresis platelet donor. And it has about 200 to 300 ml, again, about the volume of a can of soda. And it's stored at room temperature because that's the optimal temperature for platelets, unlike red cells, which are stored refrigerated. But that room temperature storage optimal has a cost, and that is we worry about bacteria. Think about, would you take a steak and leave that at room temperature for 5 or 7 days? I think you'd be, I'm not sure I want to eat that steak, right? So with bacterial testing and optimal conditions, we can store it 7 days. So we have a short shelf life for platelets. So what does that mean? That means that it's most prone to shortages. What we collect on Monday is gone by the next Monday. It outdates. And so platelets are, again, an area of focus of shortage because of their short outdate. We can't get 20 or 30 or 40-day storage time for platelets. Why do we have this product? Because platelets are part of the clotting process. They're necessary to prevent bleeding and for treating cancer patients, particularly whose platelet counts get so low that they're at high risk of bleeding. But half of our platelets go to surgical patients. So it's really to manage bleeding. This is a picture of a donor donating platelets on an apheresis machine. This happens to be a one-arm procedure. The vast majority are one arm. We talk about a personal act. Donating whole blood, you're in the chair with a needle 7 to 10 minutes. With a apheresis donation, it's about 60 to 70 minutes on average. That is quite a commitment for a donor. And so you can imagine how carefully we take care of these products because of the effort that the donor has put in. These machines are very efficient. They actually take out whole blood into the machine, spin it, return the red cells and plasma back to the donor, and just keep the platelets. And it keeps doing that for an hour, and after an hour, you can get 2 to 3 doses of platelets from that single donation. So it is now the primary method for platelet collection in the US. The last product I'll talk about is plasma. The vast majority comes from a whole blood donation. We make a packed cell, and the supernatant is the plasma. It's kept frozen, which is the optimal storage for plasma. Then we thought we can't really send a block of ice to the floor. And it is used because of clotting factors that work with the platelets to prevent bleeding. So those are the 3 products. That's 98% of the products transfused are the packed cell, the platelets, or the plasma. So those are really the only 3 to be aware of. A question that we get is, where is blood used? And there's misconceptions. It's not trauma. It's not organ transplant. It's on the orange on the right. The biggest part of that pie is the general ward. Patients who are admitted to the hospital and have GI bleeding or anemia from their underlying disease, or in this case, many cases, the cancer ward. So it's not the high-profile cases that make the newspaper where most blood is used. It's the run-of-the-mill general medical surgical patients on the floor. The ICU is increasingly a very common place for us to use blood because it's the sickest patients, and most likely where their anemia is going to cause clinical problems. So we transfuse them in the ICU. In the upper left, that brown quarter is the surgical patients. So they do use a lot of blood, but it's not most blood going to patients during surgery. And then the wedge is the emergency room and other sites. So it's not, if that quarter in the upper left is surgery, how much impact is postponing elective surgery going to have? Not a lot. That's number 1. Number 2 is Dr. Waters and I work on blood utilization, and Molly in AHN. We work together in both health systems on utilizing blood maximally efficiently, optimizing so that we use the minimum amount of patient needs at the right time. And that means that there's not a lot of extra blood being used for surgeries. Anyone want to guess, out of the 1,000 types of surgeries that are elective surgeries that are done, what % need blood? It's on the order of maybe 5%. That was a good guess, 3 or 5%. 95% of the surgeries we do not need blood because of techniques that Dr. Waters uses in anesthesia and medications that we give patients to reduce bleeding, and a procedure that we call cell salvage. We actually can collect blood that's shed during surgery, process it right in the OR, wash it, put it through a filter, and give it back to the patient before they leave the OR, called cell salvage. All these measures are in place so that we optimize the use of the precious resource of the donated blood that we have. Now, blood in emergencies has come up. We do have the ability for a physician to order blood in an emergency anytime, 24/7, immediately available in the blood bank. What blood group is it going to be? It's going to be O. So we have to have O blood for emergencies. Sometimes the physicians order 1, sometimes they order 10 at a time. And we're prepared to do that in whatever denomination they feel they need. And this need for emergency blood is not just in the hospital. It's on the life flight helicopters. It's in the ambulances going out. So we have blood stocked, not just in the blood bank lab, but in the ICU, in the OR, in the emergency room, in the life flight bases. We have 6 life flight bases in the region that we stock blood. So think of that demand on Group O. It's kind of like the common currency. It's like the euro of blood transfusion. And that's why O is an issue. And at the bottom, I want to emphasize what you heard once before, so you'll hear it twice. What's available for an emergency is not what's donated that day or what's donated the next day. It has to be what's already on the shelf because of the need for 2 days to do all the testing and all the safety measures. So we are as vulnerable as we have as our daily blood supply. Some of these will all look familiar to you. These are some of the mass casualty events that have occurred in the last few years. On the upper right is the Tree of Life. I happened to be on call that day and got the call. And as you can imagine, it was rather chaotic. We knew there was a shooting, but it was unclear how many people were injured or even where the patients were going. And through the disaster response teams at AHN and UPMC, we got very quickly the information of where these patients were going. And we immediately started shipping blood from the other hospitals to supplement what was already on site. It turned out only 5 patients needed blood, thank God. But if it had been hundreds, we would have been in trouble. We did not have the capacity of the existing blood on the inventory, that was during the summer, to handle if it was 100 patients. And so that's why this is so important. What we're doing here are not theoretical exercises. These are examples of where what was on the shelf was what was going to be available to treat. And Vitalant happened to be the blood provider, and the bottom right is the Las Vegas shooting. And I remember the day after that shooting, there was lines of donors on the sidewalks, hundreds of donors lined up. But the point was that the people that needed blood had to have been blood already on the shelf. So it's a really important concept that reactive donation is not what brings safety to the community. It's constant donation, regular blood donors. Where do we see blood shortages? We, I think, in general, are fortunate in our area because we have the ability to manage the blood supply through our hospital transfusion services. Platelets are most common. Several times a year we have shortages of platelets, half of which go to cancer patients, half of which go to surgery and ICU patients. Red cell shortages are a little less frequent, and they're usually restricted to Group O, somewhat to Rh negative blood types, which I won't get into that level of detail, but it's predominantly Group O because of the need for emergency O red cells for patients that we don't know their blood type. That's the only safe product you can give. What do we do in the hospital? So what do the transfusion medicine physicians do when there's a blood shortage? How do we safely manage patients? Well, one is we implement a triage procedure. So we actually literally take what inventory is on site, and as orders come in, we talk with the physicians and we negotiate, is what I call it. What do you need now? What could you wait an hour for? And we triage acute bleeding episodes versus, let's say, a cancer patient who needs a unit, but they could wait till 4 o'clock instead of 8 a.m. So we are triaging. We are moving blood between hospitals so that level 1 trauma centers might get blood transferred from a community hospital who had 4 extra units of Group O blood. And we have drivers that are actively buzzing around the city doing that. We may reduce the dose, so they may have requested 2. We may say, can we give you 1 now, repeat the hemoglobin, and then call me back. And we may postpone transfusions. Like cancer patients may have their platelets or red cells postponed to later in the day or even the next day. We use techniques to limit blood loss in surgery, and some of these techniques take more time and effort. A cell saver requires a dedicated person. It's a device. There's software, plasticware that needs to be used. There's a cost to that. We may use extra medications in patients to reduce their bleeding, which we might not normally use. And all those things have the potential to slow down surgery and require additional resources and cost. So there are downstream effects to having a blood shortage that actually make it all the way to the patient bedside. So I will stop there, and I think, Mark, you're going to wrap up? Okay, thank you very much.